So adverse effects, pretty much, whoop, went too far. I'll go over this slide anyway. We have alpha and beta, which is epinephrine. All of those things that rev people up, restlessness, vascular headache, can also cause hyperglycemia in some folks, and a tremor. With the beta-2 or the albuterol, adverse effect, hypotension or hypertension, a vascular headache, and a tremor are most common. Anticholinergic is if you've taken care of patients and they've had an order for a Duonev inhaler for hospitalized patients. So Duonev is 2 different drugs. It's albuterol, which is Proventil, and then it is an anticholinergic, which is typically ipratropium bromide. So this is one that also prevents bronchoconstriction, but it has a slower and a prolonged action. Albuterol lasts 3 to 4 hours. Anticholinergics last a little bit longer than that, so it hangs around in the body and helps the patient with bronchoconstriction. This is not something you would use for an acute asthma exacerbation. First line all day and every day on Sunday is going to be albuterol for that. These are some of the anticholinergic side effects. These anticholinergics basically dry things up. So that's why it's so good in the lung. It's going to dry up those secretions and that mucus that comes from a COPD exacerbation, or sometimes patients will have some secretions if they have asthma. But these are some of the side effects. Again, another drug class that is contraindicated with men who have BPH, benign prostatic hypertrophy. This can relax their smooth muscle, which can lead to urinary retention for them, which is a problem. And then also narrow angle glaucoma patients also relaxes smooth muscle and can increase the intraocular pressure. The next drug class are the xanthine derivatives. This drug class and these drugs are very old. I'm not sure if very many people are on them anymore, but the prototype drug is theophylline, and it also causes bronchodilation. It increases the force of the contraction of the diaphragmatic muscle, which is going to be really helpful with that emphysema patient. Also can be used for mild to moderate cases of asthma. Also as an adjunct drug in the treatment or management of COPD, chronic bronchitis, and emphysema. Expected side effects are cardiovascular stimulation. This drug will increase the force of contraction. It also increases the heart rate, increases cardiac output, and as a side effect, it increases blood flow to the kidneys and gives a little bit of a diuretic effect, which is a positive thing that comes with this drug. Other side effects to cardiovascular, tachycardia, palpitations, hypotension, GI effects, nausea, vomiting, diarrhea, abdominal pain. Renal effects, again, mild diuretic effect, which can also cause electrolyte imbalances. And the endocrine effect is hyperglycemia. Many drug interactions with the xanthines. Some examples, diltiazem, which is calcium channel blocker, as well as oral contraceptive pills and some antibiotics will increase the levels of theophylline because these drugs inhibit the metabolism of theophylline. Things that will decrease the levels of theophylline are phenytoin, which is Dilantin, and also St. John's wort, which is an over-the-counter antidepressant. Smoking will increase the metabolism of theophylline, so we need to teach patients if they stop smoking or they increase their smoking, they need to talk to their healthcare provider because they will not have therapeutic levels of theophylline. Food interactions, if you think xanthine, think caffeine. So patients should avoid caffeine, charbroiled meats, Alcohol, dairy products, and eating too much protein, because all of those things will impact the metabolism of the drug. These drugs are not too nice to people. They can cause toxicity. They have a small window of therapeutic. It's like 10 to 20 for theophylline levels. If your patient is toxic, they typically present with nausea, vomiting, restlessness, insomnia, some irritability, and tremors. Contraindications, patients who have seizure disorders should not take any of the xanthines. It does lower the seizure threshold. If they have uncontrolled hypertension, liver disease, or renal disease, it is also cautious use or contraindicated depending on the patient. And many of these drugs are time-release preps, so we know that we cannot crush them, put them through a G-tube. Patient cannot chew them or anything like that. Another class are the LTRAs. Prototype is montelukast. It's primarily used for patients COPD, also asthma, and it could also be used for seasonal allergy relief. This drug does not bronchodilate. It does a few other things that are helpful. And again, this is not a rescue med. This is an oral pill that will not be terribly helpful if your patient's in the middle of an asthma attack. This is how it works. You can take a look at that. Indications for use, prophylactic and long-term treatment of children and adults with asthma. It is not meant for children 12 years or younger. It also is toxic to the liver at times. So if they have liver disease, they should not be taking this medication. Corticosteroids, we know a lot about these. These can be a blessing and a curse for people. They are anti-inflammatories. They can be inhaled through an inhaler, through a nebulizer breathing treatment. They come oral form, and sometimes it takes several weeks before the patient begins to improve. Some of the inhaled corticosteroids are budesonide, fluticasone, which is Flonase nasal spray, and then fluticasone and salmeterol is a dual inhaler. Some side effects of inhaled corticosteroids, nebulizer or inhaler, they get some throat irritation. Of course, it causes coughing. It can also cause dry mouth. They can also get candidiasis or an oral thrush infection in their mouth. So we teach them to be sure to rinse their mouth after each use of the inhaler. They should be using a spacer when they're using their inhaler so they get more of that medication into their lungs. Also, they should be cleaning their spacers and their inhaler mouthpieces with warm soapy water after each use. And if they have a bronchodilator and a steroid, they take the bronchodilator first to open up their airway so it improves the surface area of the corticosteroid. Now we're going to move into infection. We're going to talk about a bunch of antibiotics. Things to know about antibiotics. You're not going to have to know pathophysiology. I'm not going to want to know mechanism of action because we don't prescribe these and that's not our gig. Things we do know as nurses, we need to be sure that the patient is hydrated. If they are not hydrated enough, these antibiotics will not travel to where they need to go, and the patient will not get better. We also should know their pregnancy category before we are administering these medications. So antibiotics, there's some definitions. Narrow spectrum is very specific for that type of organism. Example, your patient has MRSA, they have to have vancomycin or some of the other ones. So penicillin, Rocephin, those things are not going to work for MRSA. However, until we know what the culture is going to grow, they do like to prescribe ceftriaxone, which is Rocephin, because it's a broad spectrum antibiotic, or they're also using piperacillin tazobactam, which is Zosyn now, as a first-line drug until we know what the organism is. Prophylactic means we want to prevent an infection before it occurs. So example, pre-op antibiotics within 1 hour of the first incision for surgery. Or if you know anybody that has their joints replaced and they go to the dentist, they have to have prophylactic antibiotics before they can go to the dentist. For that reason, it's to reduce the risk of endocarditis or getting bacteria from your teeth into your bloodstream, travel into your heart. Empiric treatment is started based on clinical judgment before the exact cause is known. So starting a broad spectrum antibiotic for suspected bacterial infection before cultures come back, using the clinical picture and their experience to go ahead and prescribe an antibiotic to get it on board and hoping that it will work. Other things that doctors consider, missed one, sorry. Other selection considerations, effectiveness of the med. Is this drug really going to help this, or are we just wasting our time with that? Sometimes we have to look at risk of drug toxicity and the risk to benefit the patient. You think about someone who has renal disease, kidney disease, and they have an MRSA infection, and we need to really put them on vancomycin. However, we know that vancomycin is nephrotoxic to the kidney. Doesn't mean they won't get it. It means that we're going to be more cautious. The dose is going to be reduced. The time that we give it is going to be reduced, and so we're not damaging the kidneys further. Other things are cost of the drug. That's, again, not up to us as nurses. Keep missing it, sorry. Penicillin, prototype is penicillin G. The most common complication or serious complication for penicillin is hypersensitivity. They have an allergic reaction to the medication. Some of the other symptoms, seizures, rash, anaphylaxis, and nephropathy. So indications for penicillin, and this is where you don't have to memorize this. I'm not going to ask you if penicillin is effective in treating gram-positive or gram-negative, because again, we don't prescribe, we just administer. Used to treat infections of skin, GI, respiratory, soft tissue infections, and again, the cultures or how it clinically looks is going to determine which antibiotic the patient receives. Most common penicillins we all know, ampicillin and amoxicillin. These are for gram-positive and gram-negative bacteria, commonly used for UTIs, respiratory. It comes oral IM or NIV. Most common side effects, GI distress. Less common, serum sickness, kidney damage, Stevens-Johnson syndrome. This is a combination antibiotic, one of those beta-lactamase ones. Piperacillin tazobactam is Zosyn. It's used for many, many things. It's a very common, it's a highly ordered antibiotic in the hospital setting. Some of the common side effects, one of the worst is going to be a thrombocytopenia. It can also cause rashes, pain at the IV site, and some GI distress. Cephalosporin is also, you can read, used for a lot of these things. Key point, we need to be cautious in patients who claim to be allergic to penicillin, because they can have a cross sensitivity and anaphylactic reaction if they are allergic to penicillin. Commonly prescribed cephalosporins, cefazolin, which is Ancef, ceftriaxone, which is Rocephin, and orally, which is Keflex. The next group are going to be the carbapenems. These are broad spectrum, beta-lactam, inhibited the synthesis of cell walls. Carbapenem is kind of a big dog. We don't use this until or if the patient has resistant to other better antibiotics or more friendly antibiotics to the patient. It is only given IV, and the prototype is meropenem, which the brand name is Merum. Aminoglycosides, these are for gram-negative organisms. Prototype is going to be gentamicin. Also, tobramycin is here. Things to know about the aminoglycosides are they are not kidney friendly. We see a lot of these drugs ordered for E. coli and Klebsiella urinary infections. This is how they work. They are also used for intra-abdominal infections, complicated UTIs, respiratory tract infections, also sepsis, really commonly used for sepsis. These drugs are given IV and IM. Special points: nephrotoxic and ototoxic. So we should be, as nurses, making sure that there's a BUN and creatinine, that the provider is ordering that at least every 3 days. These are doses, are weight-based doses. So what's happening now, which is great, is the docs are just ordering the pharmacy to dose. So the pharmacy is always looking at the BUN and the creatinine. They're looking at their weight. They're also, it's not unusual these days to have a gentamicin that has a reduced dose that is also reduced in frequency of how we administer it. You know, it used to be like every 6, every 12. People who have kidney problems may get this drug every 18 to 24 hours. So it's not unusual to see that. Also, they need peaks and troughs for these. They will order those as well, so we know what the level is right before we give the drug and an hour after we give the drug. Lets the pharmacist know how well the body is metabolizing it. And this also comes IV and IM. Fluoroquinolones, these are gram-positive, gram-negative antibiotics. Most are given orally, but we do have some IV forms that you're probably familiar with. Ciprofloxacin, which is Cipro, and levofloxacin, which is Levaquin. Really commonly used to treat pneumonias in the hospital, GU infections, cellulitis. This and clindamycin are the really drugs of choice for cellulitis. Also, if you get gonorrhea, it's good for that too. It's also PO and IV. So as nurses, we need to monitor renal and liver function. Again, we need to make sure that the patient is hydrated, because this particular drug will crystallize and it will plug up the renal tubules, and the patient will get an acute kidney injury. Also, this drug comes from the pharmacy in a little brown bag, and that is because it is affected by light. So never take that brown bag off. If a pharmacist sends you an antibiotic or some drug in a brown bag, it's for a reason. You have to keep that on there. Levaquin is not typically used for kids under the age of 18, and a really strange side effect that can happen is spontaneous rupture of your Achilles tendon with this drug class. Macrolides, this is erythromycin, used for gram-positive bacteria, strep, gram-negative bacteria. Also, sometimes used for people who have a penicillin allergy. So examples are azithromycin, which we love our Z-Pak, and also erythromycin, which sometimes is written as EES. Used for respiratory tract, cellulitis, skin infections. Again, if you have chlamydia, it's good for that. Clarithromycin is a macrolide that is most commonly used for MAC, Mycobacterium avium complex, and it's also part of the triple drugs that are used for H. pylori. They usually call that a Prevpac. It's clarithromycin, one other drug, sorry, I can't remember, and like a PPI. Must be given with food for best absorption, and erythromycin has a tendency to cause some GI upset unless we give it with food or milk. Lots of drug-to-drug interactions with this, so it may increase the metabolism or lower the metabolism. I'm not going to ask you that on the test, but know that it can interfere with Coumadin, which is warfarin, theophylline, prednisone, digoxin, which is Lanoxin, and carbamazepine, which is Tegretol. Also, not kind to the liver, so we need to be careful with patients who have liver disease, or of course if they're allergic to the drug. Most common side effects are going to be GI distress, but dose-related tinnitus or ringing in the ears can occur with erythromycin, and patients report dizziness sometimes. Oxazolidinones, that's a big word. The prototype is linezolid. I can't remember what this, I think this is Zyvox. Really ugly, nasty antibiotic. Used for aerobic gram-positive bacteria. You can see here bacterial pneumonia, septicemia, skin and structure infections. Also, patients who have developed VRE, which is vancomycin-resistant enterococcus, will have graduated to Zyvox. Can cause myelosuppression, so that's going to be bone marrow suppression. So we're looking for low red blood cells, low white blood cells, and low platelets, because our bone marrow create all three of those things. Also can cause pseudomembranous colitis, which is a very ugly diarrhea and intestinal infection that causes the walls of the colon to slide out as sludge. Routes IV and PO. Nitroimidazoles, this is metronidazole is the brand name. Sorry, that's the generic. Brand name is Flagyl. Very ugly drug. Causes lots of people to be sick. It's effective against anaerobic bacteria, gram-positive bacilli, also used for bacterial vaginosis. This drug must never be taken with alcohol because it will cause the patient to be deathly sick and just throw up their toenails. So we should be teaching patients, particularly if they're getting it for an STI, a younger person, not to drink with this drug. Glycopeptides are the other one. Vancomycin, we're all familiar with that. Gram-positive only. Again, this one is nephrotoxic as well, so we need to monitor our BUN and creatinines in our patients. Frequently used drug of choice for MRSA in the hospital setting. If we give it too rapidly, it's dripping in IV, we can cause hypotension, flushing, and a skin rash. What we can do about that, if that occurs, is we have clinical judgment to slow the rate of that antibiotic down, and that should help with that. You've probably heard resistance is mounting to this drug because it's been used so frequently and so overused. And again, another problem with giving too quickly, it can cause red man syndrome. Antivirals, we're just going to briefly talk about acyclovir, which is used for the herpes virus, also varicella, which is the chickenpox virus. People get cold sores on their mouths. This herpes virus will live dormant in that cell or in the root of that nerve, and when they're stressed out or something occurs, they can get a breakout from that. Oseltamivir is Tamiflu, which is used for influenza. Strange thing about Tamiflu, it must be started within 48 hours of their symptoms to be effective. Doctors will not prescribe it if you've had symptoms for more than 48 hours, and the course of treatment is 5 days. It doesn't stop the flu, but it slows down or makes the symptoms less severe. And the last one, next to the last, antifungal meds. You've probably seen this too in the hospital setting. Nystatin, swish and swallow, or mycostatin is the generic name, used for thrush, candida infections, diaper rash, esophageal candidiasis, vaginal yeast infections. It comes as a vaginal suppository, an oral rinse, topical as a cream, or they can also take oral, they call them Troche lozenges that will dissolve in their mouth. And the last one is fluconazole, which is an antifungal. This is diflucan. It's a synthetic drug. It's a broad spectrum used to treat candidiasis and some really strange bacterial infections. It comes PO or IV. There's a sister drug to this, which is called ketoconazole, and this one has much fewer side effects than that. Again, it is not kind to the kidney, so we need to monitor our BUN and creatinine.